Today I will tell you why patient co-payments are a good idea, but only for those who are rich and healthy. The increase in healthcare spending in almost all OECD countries is a historical fact. Expenditures grow faster than the gross domestic product, and this trend will continue. Due to well-known factors, a rise from an actual average of 6% of the GDP up to 9% in 2030 and 14% in 2060 is projected. Co-payments in high-income countries are relatively stable and account for approximately 18% of healthcare expenditures in the EU 28 average. In Austria, as an example, 8.5 billion euros were spent on healthcare per private co-payments in 2015. One can easily see that an increase in public health expenditures due to abolishing private co-payments would put substantial pressure on national budgets in high-income countries. Therefore, by 2019, co-payments are a reality in every of the EU 28 in one or another way. So the question, if co-payments are a good idea, is an abstract and idealistic one. The focus of a more pragmatic discussion should be set to a deeper look into where co-payments are good in high or low-income countries, how much co-payments are good on a patient and system level, what kind of co-payments like direct payments, cost-sharing or informal payments are good, and for whom are they good, based on the patient characteristics and their socioeconomic status. Furthermore, the question should be in which part of the healthcare system co-payments should be implemented. In today's lecture, I will show you that in a high-income country like Austria, private co-payments of approximately 25%, capped to approximately 1,000 euros, based on cost sharing, especially for those who are rich and healthy, is a good idea in all parts of the healthcare system. A recent meta-analysis investigated the effect of co-payments on behavioral changes associated with good health status. Private insurance or high deductibles are commonly associated with practicing more sports, being obese less often, and smoking less. Furthermore, the Rand Health Insurance experiment provided robust data on the effect of co-payment on healthcare utilization. In general, co-payments reduce healthcare utilization and health spending, with no overall effect on the quality of healthcare and outcomes. In another time series analysis, a reduction in emergency department visits was observed after introduction of a co-payment system. Notably, this reduction was only observed for conditions considered no emergency, while visits for emergencies did not decline. However, some controversies exist on the impact of co-payments on healthcare quality and outcomes, especially in high-risk groups, as signals exist that co-payments pose a significant threat to the access of healthcare and subsequent outcomes for these patients. Data shows the fact that patients with low income experience problems to access healthcare system. Due to costs, prescriptions were less often filled, recommended tests and follow-ups were less often performed, and doctors were less often attended for medical problems in the below-average income group as compared to the above-average income group. Furthermore, a closer look at the Rand data does suggest a benefit of free services for patients who are poor and sick. They state that the poorest and sickest 6% in the experiment had better outcomes under the free plan. This was especially true as hypertension was more often better controlled and a reduction of hypertension-associated mortality was observed. Vision improved, dental health care was more often received when needed, and patients less often presented with serious symptoms like chest pain, bleeding, or weight loss. Based on this observation, we can summarize that co-payments reduce moral hazards and do not affect healthcare access in patients with above average income and who do not suffer from chronic conditions. This suggests that co-payments for rich and relatively healthy people reduces cost restraints for the public health system, overuse of the medical system, and even might enhance health due to a healthier behavior in this group. Therefore, a differentiated system of co-payments for those who are rich and healthy is a very good idea indeed.